Good afternoon. Welcome to the Foundation for Opioid Response Efforts webinar series on maintaining access to opioid use disorder treatment and recovery services during the COVID-19 pandemic. My name is Ken Shaskis. I am the Senior Program Officer at FORE. FORE is a national private grant-making foundation aiming to support solutions to end the opioid crisis. As you all know, the opioid crisis now intersects with the current global COVID-19 pandemic. We are using the foundation's resources to convene expertise on what this means for the populations at the center of our work, as well as the providers who care for them. Today's webinar will focus on the primary care safety net and the role of community health centers, an important access point to treatment and care for many vulnerable patients experiencing opioid use disorder. I will review some logistics and then turn to our fantastic panel for their presentations, followed by an open question and answer session. So this webinar is being recorded and will be made available along with the presentation slides on our website shortly after the session ends. Please use the Q&A box that is found at the bottom of your screen to submit any questions for our panelists. If you see a similar question has already been asked, you can upvote that question using the thumbs up button below that question. This will ensure we can get to the most pressing questions first. For those that we can't get to, an FAQ will be provided on our website based on all the questions we receive. There will also be a brief survey at the end of the webinar, which we would appreciate your feedback on. So at FORE, we are continuing to expand the information and resources on our website, develop future funding opportunities, and communicate about critical issues at the intersection of the opioid and COVID-19 public health emergencies. We welcome your suggestions for future webinar topics and projects. Please feel free to contact us and follow updates on our website at www.forefdn.org. Now, I am so pleased to welcome Drs. Shuchin Shukla and Blake Fagan from the Mountain Area Health Education Center in Asheville, North Carolina, Dr. Vaty Poitevien from Housing Works Community Healthcare in New York City, and Dr. Sue Lin from the Bureau of Primary Healthcare at HRSA, as they are going to be leading the presentations today. I'll now hand it off to Dr. Shukla and Fagan to start off the presentations.
Great, thanks so much, Ken. And we do have a third member of our team here from MAHEC joining, Dr. Macy Ladder. And so she'll introduce herself when we get to her section of our brief presentation. And so I'm a family doc here at MAHEC. MAHEC is in Asheville, North Carolina, and Western North Carolina. So our project is really geared towards expanding care for our rural FQHC and community health center network, particularly in North Carolina. And so part of our role here at MAHEC, and you can go to the next slide, Ken, our role here at MAHEC for many years now has been as a regional leader in providing support across a variety of clinical issues, including what is now our main issue, which is COVID. But over the past years, we've developed our own capacity to treat opioid use disorder, as well as train and mentor other providers across Western North Carolina and the rest of the state in lifting up these programs, particularly in residency programs and PA and NP programs, until we were graced with the generous funding from FORE to expand that kind of work towards FQHCs and community health centers. And so our presentation will focus on this system of safety net providers and how COVID has affected their ability to provide opioid use disorder. So Asheville is a relatively small city of 80,000 people. The county has 200,000 people, but we are the regional hub for about 18 counties that are all very rural. And so we're literally the biggest town in the area. And as you might have seen in the news, I'm sure many of the participants are familiar that Appalachian parts of the United States have been particularly hit with overdose death. Slide, please. So I'm going to touch on this slide just sort of the concepts that we've been experiencing with COVID in terms of providing OUD care in rural areas in Western North Carolina. But then we're going to touch on some specific patient cases that each of us, between myself and Dr. Fagan and Dr. Latter, have experienced in our patient care and how we provide OUD care. So I know Hannah Snyder did a great job on the first FORE webinar going over some of these issues. So I'll touch on them briefly. But so for our patients, the main issues have been related to income loss and insurance loss, often because of the disruption in employment in Nashville, particularly. A lot of the economy is driven by tourists and visitors. And so because of that, shutting down has really affected people's access both to income, to pay for medications and healthcare as well. Additionally, housing, with folks being more locked down, has provided triggers for some folks who are struggling with substance use disorder, maybe because they have a partner who uses drugs, or they have a partner that causes them to want to use more drugs. And then there's been less access to community support, like group support, as well as other activities that help relieve some of that stress and prevent those triggers from being acted upon. In terms of actual drug use, we've seen disruptions in drug supply, and so that's kind of gone in both ways. There's been more risk of contamination as people are having to purchase drugs from sources they may not be as familiar with. And on the other hand, some folks have not had access to a steady supply of their drugs, and so have had to be forced into withdrawal situations again, while holed up in living situations that are not conducive to experiencing that. And so that's actually prompted more use of patients using alone is something I've noticed in my personal patients, and that puts its own risk of overdose when there's not someone around to help if you need help. And then healthcare access actually has gone both ways, and so we'll be illustrating that in our cases, but providing telemedicine, I'm at a point where I'm providing about 90 to 95% of my clinic visits are through video or audio only platforms. That's opened access for a lot of patients who previously were struggling with transportation, living in disparate areas that may or may not have good transportation services. But at the same time, we've seen specifically patients with more rural locations struggling with their Wi-Fi and broadband access, or even just cell phone access in some locations. For providers, telehealth has been a boon for having access to these patients, but at the same time as we provide OUD care, we've had less drug screening, as you can imagine, since people aren't coming in person, and less ability to collaborate with our behavioral health colleagues or even with each other. But like I said, we've had better show rates because I've had patients who are calling me during their break at their job at a grocery store in town to get their prescription and check in with me. So that's been really helpful for patients. Staffing has been problematic, and hopefully we're kind of getting towards a new stage in that evolution, but childcare issues, whether providers are on quarantine after a stint in the hospital service, some providers struggling with IT issues as they do these video visits, all have contributed to a new era of providing primary care-based OUD care. And then at the health center level, and I'll leave some of this to Dr. Latter, that for some health centers, revenue has gone in different directions where there's been less in-person visits, which have traditionally been the source of revenue for health centers, and more phone triage. And I think a lot of health centers, including ours here at MAHEC, have shifted to doing more telemedicine, and luckily, and we'll hear this from Dr. Lin, of how the federal government has supported some of these changes, but we have been able to keep up with our revenue needs to provide care to our patients. And so this is all in general led to restructuring of roles, of our space, of our priorities, and in a situation where everything is harder in rural areas. And with that, I'll, a slide please, and I'll leave it to Dr. Fagan.
Great, so just checking in, Ken, you can hear me?
Yes, we can.
All right, great. So I was going to give two cases, this slide and then the next one. We'll start with this one of an instance where in the era of COVID, the telehealth went well for a patient, and then the second case is one where it didn't go so well. So this first patient was a patient that was leaving from one of our alcohol drug abuse treatment centers. They call it ADACs that are in North Carolina. We have 3 of them. Each one covers about 33 to 35 counties. So the whole state has 100 counties in it, and we've got 3 ADACs. So typically in the past, pre-COVID, someone would get ready to leave ADAC. And that's where you wish you had a nice warm handoff, but it just never went very well. Patients would not have medication long enough to get to the next provider. The patient may or may not return to use, may or may not keep that appointment, those kind of things. But in this patient, what happened was, so we got a call from the ADAC and said, hey, this patient's getting ready to leave. Can you see them? And we said, yeah. And then because it was telehealth, I was like, I can see them right now. So literally within an hour of them leaving, they were on the video with me. I said, hey, how are you doing? We went through all of our questions with her. And then I sent in her buprenorphine combo product to her pharmacy, and then scheduled an appointment in 3 days to have another telehealth appointment. And she made that appointment. She had picked up her medicine. She had been stabilized in the ADAC and continued to be stabilized in the outpatient setting. She was super grateful for that connection that was, again, literally within an hour of discharge, and the fact that she didn't have to fight for her med or was worried about where it would be or prior auths and all that stuff. All that was broken down, and she was able to pick up her med, continue to have her brain stabilized, and see me. And I've continued to see her for the last 2.5 weeks now. She's doing well. Next slide. And so then this is a case of someone that did unfortunately destabilize. So some of our patients that we were seeing pre-COVID would be in the maintenance phase, and we'd eventually, if everything went well and the urine drug screens were fine and everything, they would be out to seeing us once a month. And so I connected with this patient after knowing that he's been stabilized for a year, and I looked back, the last 6 months of his urine drug screens were as expected, which was buprenorphine and nothing else in them. And I got on the phone with him, and he said, you know, I've lost my job, and I actually didn't realize how much structure was in my life, but I had my job for about 9 or 9.5 hours a day, if you including commuting. And then I was going to NA at least once a week, but usually twice a week. Well, my NA was volunteer, and it was run by an older guy, and he just never could figure out, or hadn't, at least to this point, figured out how to do Zoom or WebEx or anything. So our patient hadn't been going to NA. And then he's spending more time in the home with his spouse and kids, and it was frankly stressful for him. And he said, you know, I've returned to use. So the COVID in that case did not help at all. The structure that he had in his life had all fallen apart. And then the only saving grace, I would say, in this, or the nugget, is that because we'd been seeing him in a non-judgmental way, when I did say, like, hey, have you had any return to use, or if we were to get a urine drug screen, so parenthetically, we're not getting urine drug screens on our patients. We decided in the harm reduction model that we will see them by telehealth, and then having them be seen by telehealth, but then still have to enter our clinic, touch the doorknobs, go to lab to give a urine drug screen. We decided that we weren't winning if we would give one of our patients COVID. So at the present moment, with some exceptions, we're trying to see our patients by telehealth and not requiring a urine drug screen. So in this case, this is what I say, like, hey, you know, we've been visiting each other for a year, and you know, you've been straight with me, and I'm not going to kick you out, but if we were to get a urine drug screen today, would there be anything in it? And he's like, yeah, and told me everything that would be in it. And I said, it sounds like you've returned to use. Yes. And then again, gave the scenario I just talked about. And then I was able to get or link him to behavioral health that day. And then I only sent in a week's worth and said, I really want to see you in a week. And he said, yeah, I really think I need some kind of more structure in my life. So we sent him in the buprenorphine, saw him back in a week. And then also, just to let you know, subsequent to that, he's been doing better, but that was an example of how the COVID has caused some people to return to use. And next slide then. And
Thanks.
I'll pass this back to Dr. Shukla.
Thanks, Dr. Fagan. So I'll just piggyback on that case briefly in the interest of time. So I also had a similar patient with a slightly different outcome, but pretty similar, where a patient who was one of my group patients, so I was seeing monthly and for several months with a pretty consistent group, who I did a typical video check-in with, and she had said she was doing well, but she also complained of dysuria. So I said, well, you know, why don't you come in, and at least in the next couple of days, I'll send in some empiric antibiotics, but let's come in and so we can get a urine culture. And then we have sort of a standing order system where if someone's coming in for a urine and they have OUD on their diagnosis list, the nurses tend to order a drug screen. So she actually had a drug screen, and you know, I have a pretty good relationship with this patient, and she denied that she had had any return to use, but you know, her urine had amphetamine and benzodiazepines, as well as her buprenorphine, and also had tramadol at a very low level. And we sent it for confirmatory tests and had the same. And so, you know, I talked to the patient again in a video chat, and then had her come back in, and she, you know, talked about the shame, and she didn't want to talk to me about her return to use because she's been under more stress. She's living with her mother. She has a criminal background history, and so she has to live in this address because of her I think probation requirements. So she's in this stressful situation that triggered her. But the interesting thing was, what was most concerning for her is she had no idea where the tramadol came from. She really was confident, you know, and even before I talked to her about the results, she told me there would be amphetamine and benzodiazepines in the urine, but and those things did not affect her emotionally, but she really cried really hard when the tramadol was in there, because she knew as well as I knew that could easily have been something stronger that maybe would have overcome the blockade that buprenorphine can do on the opioid receptor. So it really illustrates sort of the challenges of not having urine drug screening, not having that same human-to-human kind of contact that I think is important for our patients, as well as the dangers of contamination of the drug supply. Next slide. And so I'll turn over to Dr. Latter, but briefly, just to introduce her, she is a physician at Blue Ridge Healthcare, one of our FQHC partners here in Western North Carolina. She's been doing OUD care for years in Brevard, North Carolina, a very small town. And so I'll leave it to you, Dr. Latter. Oh, and I just wanted to, this photo, it just shows a wider view of MAHEC, and sort of shows that we're in town, but we are surrounded by wilderness, and people come as tourists to experience this wilderness, but it really shows the geographic isolation for some of our patients. And so you could picture out in the mountain there in the distance is where Dr. Latter's sitting right now. I'll leave it to you.
Great, thank you. So, you know, we've talked about how rural medicine is certainly challenging in many ways, but working for an FQHC makes it easier in a lot of ways as well. So I'd like to highlight some of that we've experienced through this COVID crisis. So through our program, we've had at least 4 new participants just in the past, I'd say, month. And one guy really stands out where he came in and was really concerned because he had been doing well in his recovery and had been seeing another outpatient private provider, but could no longer afford to see him because he had lost his job and lost insurance, and he was paying up to $100 a visit, plus $100 plus for his medications, and he had heard about us and was just kind of at a loss of what to do. So since we are an FQHC, we function on a sliding scale situation with payments. Almost just under half of our total patients at Blue Ridge Health are uninsured, and they qualify for our slide scale. But most importantly, what that qualifies them for is access to our 340B pharmacy program. And if you're not familiar with that, it's a federal government program that was created in 1992, and it requires drug manufacturers to provide outpatient drugs to eligible healthcare organizations at significantly reduced prices. So for example, I was able to offer this patient brand name buprenorphine naloxone film. For 56 of those, he could pay $12 a month, or $12. The generic tablets, he could pay $38. And that's significantly reduced from what he was paying before. And he was very relieved to have that as an option. So fortunately, even with our patients struggling with the job loss and financial stressors created by COVID, you know, we can still help them afford their medications and also give them access to our behavioral health team. As an FQHC, we recently qualified for a grant to expand our behavioral health services. So we hired in our clinic, we hired a RN case manager, and she helps to coordinate our program and make sure that each of our participants is hooked up with a behavioral health provider, and they're meeting with them, you know, initially weekly, and then we expand it as appropriate. And what I have heard from my behavioral health team is that counseling visits have actually increased through this COVID time because there's better access for telehealth. You know, my patients struggle with transportation and missing work. So we've actually had an increase in participants, and it's been really good to be able to provide some hope in this, you know, time of crisis.
That's awesome. Thank you so much, Dr. Latter. And you can go to the next slide. So I'll wrap up here, and hopefully we illustrated some of the challenges as well as some of the solutions, and really the resilience of our community and our health infrastructure here in Western North Carolina. But to bring it back to our actual FORE project, so as I mentioned earlier, we have this program, and I didn't mention that our collaborator in this is Dr. Robin Jordan, who's an addiction psychiatrist based out of UNC Chapel Hill. So there's really a multi-organization effort. But our plan is to train up these spokes across the state that are focused on the service of folks without insurance or with underinsurance or transportation issues, whether that's FQHCs or community health centers or rural health centers, and then develop a hub here at MAHEC as well as at UNC to improve this network and allow for care for patients who need a higher level of care, as well as care that's more geographically located with their primary care. And so some of the challenges we've experienced with that is just the priority both for hubs and spokes have changed as we're making sure we're keeping our staff safe, but keeping our communities and patients safe. We have had more telehealth, both in spokes and hubs, but again, questions of quality of care as we illustrate in our cases. And then in hubs, we've, you know, Blake especially has done a ton of in-person trainings across the state. He's well known in Western North Carolina in training for OUD care. And so now we're having to pivot to virtual trainings, which really changes things. I can imagine there's some of you listening right now who may be distracted with your Facebook or something. And so it really changes the nature of how education works. And so we're all learning how to do this better. And then for spokes, again, transportation, less of a barrier, but maybe the technology is. So we're still learning the best ways to provide care and provide training and technical assistance to our communities and partners. And with that, I will turn it over to Dr. Poitevien from Housing Works in New York City. Thanks.
Thank you. Hi, do you guys hear me?
Hear you loud and clear.
Perfect. So I'm here from Housing Works. I'm Dr. Vaty Poitevien. I'm the Chief Medical Officer. Here with me also is Bethany Davinson. She's the director of our MAHEC program, and I want to give her thanks. She did help me with the slides, and I'm very grateful, Bethany.
Hello, and thank you.
Next slide. So this is our mission really for us. It's a commitment to quality services, quality care for our patient, but this through empowerment and social changes, which for us mean harm reduction. Next. So we are in New York. We are in New York City. We have 5 sites in New York City, 5 clinical locations, 3 in Manhattan and 2 in Brooklyn. And we don't have the kind of wilderness that we just saw before. We're very jealous when we see that. We provide at those sites, next slide, we provide primary care, HIV care, Hep C, and behavioral health. We provide both psychiatric care and psychotherapy in Article 28 through FQHC. We have case management, multiple case management program, intensive case management, health home case management. We provide housing. Our two of our clinical locations also have housing, vocational training as well. And then evidently we provide Suboxone treatment and MAT. We do not provide methadone. Next. Some of the photos, I clicked next, but some of the photos were initiatives that we had that we used for our MAHEC program, and we'll talk about that later. So with the population that we treat in New York City, which is really a population of marginalized and underserved population, we do tend to see higher rates of chronic disease and a lot of patients with barriers. So we have high rate of Hep C, HIV, but also we can see that 63% of our patients have an income below the poverty level. 8% have no known income. We treat 41% of patients that are homeless, 16% uninsured. Our demographics are 53% African American, 24% LGBTQ, 4% are transgender or gender non-conforming, and 67% are male. Next. So a little bit about our MOUD program at Housing Works. We started in January when we got our grant. And really the first step for us was to start implementing, changing our protocols. So the first, I would say our challenge was to make sure that we integrated MAT into primary care and behavioral health. We wanted it to be part of our routine care and not to be, stigmatized in a little area of the clinic. So we made sure that all our providers were waivered and were able to prescribe Suboxone. But additionally, we made sure that they were also, they had training in harm reduction. And getting waivered, unfortunately, doesn't really necessarily mean that you have the training to provide Suboxone adequately. And we train our providers, and we actually continue training them. The other thing that we did was to create an MOUD subcommittee, really a group that included case management, included our behavioral health and psych providers, but also our quality and data team. And that was very helpful for the current situation. Their role was to start creating, looking at the initiative and looking at how we could improve the care through projects and through small pilot projects. The last piece of that was for us was our clinical protocol. And our current clinical protocol for MOUD is called MAHEC, and this is linking medication-assisted treatment with therapy. And this is based on the impact model. So really based on the inclusion of low threshold psychotherapy with the medical or prescription of Suboxone. We also have care coordination in the LMAT program and a peer outreach, which we felt was very helpful for us to have. So we have at each clinic peer advocate that help with the linkage and help with the care, it help with the care coordination for our patients. Next slide. So, and then this happened. So coronavirus happened, and we were called the worst coronavirus place in the States was in New York. So at that point, we scrambled to implement telemedicine. Now, one of the pilot projects that the team was working on was actually a telemedicine pilot. It was a small pilot with one provider at one clinic. And we really rushed to, to extend it to the whole practice. It was a huge challenge, a very big lift for us. We had to train both the providers and the patients. And evidently, as all of you on the line know, we also had technical barriers. We focused on one telemedicine provider, which was linked to our electronic medical record. We have ECW, eClinical Works, and we use their ELO app. We really didn't want to, some providers wanted to do FaceTime, Zoom, and we really tried to channel it all to one system so we could also give the technical, it would be easier for us to give the technical assistance for one system. We deployed our quality staff. So our quality and data team was redeployed to do first outreach. So a big part of their role became to do targeted outreach to the MOUD patient. In their previous role in the subcommittee, they were creating registries of patients that had MOUD diagnosis and reporting on their adherence or attendance to appointments. We tasked them at that point to actually be the one outreaching those patients and making regular calls and making sure that the patients were connected. But additionally, they would, when they would get the patient on the phone, they would teach them how to use the app. So they would make sure that they were linked to the electronic medical record, linked to the portal, which a lot of patients did not have. And they would download the app with them and teach them how to use the app. Another portion of the quality staff was then deployed as what we call helo helpers. So they were in the clinic for patients that actually would come into the clinic doing the same thing, downloading the app and helping them, but also helping the providers when they would have any kind of technical difficulty connecting. The technology is there, unfortunately, it's very imperfect. And I think we all can see that. So I talked about their role in outreach. Their role in outreach was also intensified. Before COVID-19, a patient would get a call, a reminder call the day before the appointment, and a reminder text the day of the appointment. They would, after COVID and up to now during COVID, what we're doing is that we're doing as many calls as possible to get a live person. But because before the team would call and you would get a message saying, you know, attempted call, left a message. The goal for this was that we needed to have a live person and a true contact before you stopped. So some patients will call 3 times, 4 times, 5 times if they had to until they got a live person. For certain patients, then we ended up having to distribute cell phones for fragile patients or that either did not have a phone, which was rare, but a lot of patients had what they call the Obama phone. They're phones that are not smartphone, or patients that had broken phones. So we invested in distributing cell phones so they could connect with us. And then we adapted our policy. We normally have a policy of having a urine drug screen at every visit, which right now was not possible. As the previous speaker stated, you're not going to have someone come to the clinic who is getting contaminated just to give you a urine. And since right now that need was waived by the DEA, so we also adapted to that and let our patient know during those calls that they didn't need to have a urine and they could actually connect to the provider remotely. So you have a little bit, if you look at the numbers on the left, we started with telemedicine. We started in March, but this is this month. And at the last week, so 5/1, if you look at it, we were able to have 53% of our primary care visit overall through telemedicine and 63% of our behavioral health visit through telemedicine. We've gotten more success with psychotherapy and psych than with primary care, which it makes sense. Those two practices were already, you know, some of them, some providers that were already doing telemedicine with their private patients. But you see our numbers are very small in comparison to other centers. And this speaks to the population that we have. A lot of our patients are still reluctant to do telemedicine and still show to the clinic. I mean, it is what it is, and we are there. They're providers at the clinic to serve them. We try to make it as safe as possible, but we have to realize that this has been with a lot of effort. I think that half of our practice is probably where we're going to stay with televisits. Next slide. So we were very worried, and we were really expecting to have a drop in our visit. I actually had even the conversation with Karen before I saw the last data, worried that I wasn't seeing some of my patients. Where were they? But the data belied that totally. And I think I'm not the only one. I see speakers before having the same experience. We actually increased our Suboxone prescription and increased our visit. So for March to April, our numbers went to 431 Suboxone prescription compared to 345 the month before, and the number of patients seen also went up. The number of unique patients went up from 196 the month before to 214. So this is really a combination of patients being at home and not having other things to do. New York is really at a standstill, but also of the outreach, because as you see, for us, it's not just on the phone. Patients are coming to the clinic, and that was really something that we were very happy that we were able to still serve our patients, and that patients were not, as we were so afraid of, relapsing and going back to using drugs and not keeping with the treatment. The other thing that we've seen is that the visit because our LMAT program includes psychotherapy, the visit for psychotherapy, which is not noted there because this is just the Suboxone prescription, but the visit for psychotherapy have been maintained and the patient have been accessing psychotherapy. And actually, some of our patients that were not interested in psychotherapy in the beginning now are asking for psychotherapy. I had 2 patients of mine yesterday asking to see a psychotherapist, which was very, very exciting for me because I've been trying to get them there. Next slide. So what did we learn? So we learned that building out telemedicine is a huge lift, and however, we see how much telemedicine enrich the practice and what an opportunity it is for our population, but it is still a big lift for us. This is something we would like to continue implementing, the telemedicine option for our patients. I feel that was extremely helpful. The other thing that we learned is that our registry, drilling down on the MOUD population and having the quality team work on that population was extremely valuable. I was on a call before with operation person, and really what we want to expand that to other department, and we wanted to try to see what did quality do. So part of what the quality team did was that their outreach was extremely systematized and organized, and they built regular reporting. So the quality team had daily report on the number of calls, how many patients they were able to reach, which provider they were working on. And I think that that's a difference from what we were doing before with outreach, where we were, first off, outreach is usually a task that you give to the very entry level team member, and really you give them a phone and they call patients. And the quality team really, well, that's what they do, data and quality. So the quality team really brought some reporting and data mining that was helpful. And then through our challenges to meet, we started doing telecase conferencing, and that's also, so it allowed us to keep in touch with our other team members, because that's a big part of the LMAT program, that the behavioral health team and the primary care team should collaborate, and we see a need to continue doing that past COVID-19. Next slide. So to end, it's really where we think we can go past this. We really think, and I personally think, that it would be terrible to get that pain and not have anything positive coming out of it. And for MOUD, what I see is really that, you know, we do this with an always, and this is coming from the agency that regulates us, and there's always an eye on diversion. And really, during this period, we realized how much harm reduction and continuity of care were really what mattered. And a lot of our patients needed that. And really trying to see if we can focus less on that and more on keeping patients, you know, healthy. I talked about expanding telehealth for this population. I think this is, and I'm so happy that I heard that from other providers in other part of the country, how much this would help this population. And I think one of the barriers is the urine testing, which we, you know, it's sometimes clinically necessary, but we might try to find a way around that. I talk about incentivize for buprenorphine. We at Housing Works have 2 programs right now with incentive for adherence. One is for HIV treatment, the other one is for Hep C treatment. They are extremely successful. And I think that there is some incentive right now for methadone in New York City. I think having some kind of incentive for buprenorphine for specific population would be helpful. Well, the targeted outreach, I talked about it at length. I think that just opened our eyes, and that's something we're definitely going to do. We were just in building our toolkit for retention and adherence for our LMAT program. I really feel that we're going to keep some of the things that we started doing, and even something like the free phones for some of our patients were really great to keep our population. And then lastly, really making sure that our providers and our care coordination programs continue to be linked. I think right now, we all got used to Zoom and use Team and use teleconferencing for a lot of our meetings. And I think that that could also make our relationship inside our practice much easier than have people come for a sit down, you know, care coordination meeting. That was it for me. Thank you. I'm going to introduce Dr. Lin. Dr. Lin, take it away.
Thank you so much. Next slide, please. I would like to take a moment to acknowledge and recognize all of the healthcare provider heroes on the panel with me and those in the audience. Thank you all so much for what you do. Also, I know that this is National Nurses Week, so I would also like to take a moment to recognize the nurses for all their hard work, compassion, and dedication to patient care. Thank you for the opportunity to spend a little bit of time talking about HRSA's Health Center program. And I know, you know, we're running a little bit short on time, so I hope to run through my slides and then give you all an opportunity to ask us questions. So the slide that I usually like to start and sharing about our program is the Health Center Reach slide, in which our mission is to increase access to primary care nationwide in underserved communities. The Health Center program has been in existence for 50 years with the goal of delivering affordable, accessible, quality, and value-based primary care to millions of people, regardless of their ability to pay. And Dr. Latter had already alluded to that in her earlier presentation. Today, HRSA funds nearly 1,400 health centers, which roughly translates to about 12,000 clinical service delivery sites in every state, territory, and District of Columbia. Our latest data in 2018 tells us that our workforce is over 200,000 full-time health center providers strong, serving 28.4 million patients. And that has really tripled from the year 2000, where we were serving 9.6 million patients, to 28.4 million. And so we are extremely proud of all of the health center providers and in fulfilling the mission of increasing access to primary care in underserved communities for our patients. Next slide, please. So the organizers asked me to talk a little bit about COVID-19, and certainly that has taken over a big part of our life. With the health center program's COVID-19 response, within the Bureau, we set up a response incident command, to be able to respond to the increase that came from the health centers, as well as to administer the funding that came through, through several iterations. So I will say that for us, on March 24th, HRSA awarded $100 million to health centers across the country that was provided by the Coronavirus Preparedness Response Supplemental Appropriation Act. And that funding was to address screening, testing needs, and help health centers acquire medical supplies and boost telehealth capacity that several of my panel members have alluded to earlier on. And then following that, on April 8th, HRSA announced a release of more than $1.3 billion that was provided by the Coronavirus Aid Relief Economic Securities Act, or CARES Act. And that, with that funding, health centers can use the funding to help communities across the country to detect the coronavirus, prevent, diagnose, and treat COVID-19, as well as maintain or increase health care capacity and staffing needs to address this public health emergency. And then as of today, this morning, we put out a third set of funding called the Expanding Capacity for Coronavirus Testing Award in the amount of $583 million that provides one-time funding support to health centers to prevent, to prepare, and respond to the COVID-19 public health emergency. In terms of our testing capacity, we have been conducting a survey on a weekly basis to capture that information, and about 88% of our health centers have that testing capacity. The visits, folks have alluded to earlier that in-person patient visits have gone down, and that has been a primary source of our health centers' revenue. And so right now, the weekly visits compared to pre-COVID is about 56%. Over 1,800 clinical sites have been closed. That includes those that are situated within our school-based health centers, our dental sites that are working in adherence with the CDC and state dental service guidelines. Over 500 of our health center staff have tested positive for COVID-19, and about 12% of our health center staff are unable to work due to site closure, family and home obligations, PPE limitations, and over 53% of the health center visits are now conducted virtually. Dr. Letter alluded to a funding opportunity that we put out back in 2019, and we've been supporting the expansion of substance use disorder services and mental health services since 2014. And so we, continue to invest in expanding that capacity. And one of the questions that we had received in COVID-19 was, were there flexibility to use, previous funding that supported substance use disorder expansion to respond to COVID-19, such as, staff using laptops purchased through the funding for telework and telepsychiatry equipment to support virtual COVID-19 assessments. And we've been able to put out a frequently asked question response that they had the flexibility to use the equipment and supplies purchased previously to support in-scope activities at their health centers. Health centers have asked us these other questions about linked to remote practice and telehealth, in particular, how to coordinate primary care, behavioral health when staff are telecommuting. What are some of the issues that are presented in integrated care when using telehealth for service delivery? And then how to conduct follow-up medication-assisted treatment visits with patients and best strategies for team coordination and care delivery. Next slide, please. I want to quickly talk about the health center model of primary care, and you see that the components of primary care is what we call comprehensive primary care integration that includes behavioral health, that includes substance use disorder service, oral health service, and enabling service. And we really value the interdisciplinary team that supports the preventative care and the treatment that can be provided from that interdisciplinary lens. And our investments have been put forth to build the workforce capacity to support access on each of these aspects. And so you'll see an increasing trend across all of the workforce categories that have been highlighted here on increasing that capacity. Next slide. The other piece I also want to share is our support and commitment and investment in patient-centered medical home model, which supports the delivery of behavioral health services within our health centers. Placing that patient at the forefront of care, and through the implementation of patient-centered medical home to build that relationship between patients and their clinical care teams, and then supporting our goals of continuous quality improvement, improving the patient experience, as well as that third triple aim of reducing healthcare costs. Next slide. So I think, want to take a moment to sort of revisit what we have achieved collectively pre-COVID. This is a data element that we have been tracking for some time, screening, brief intervention, or referral to treatment. And you can see the steady increase and climb from 2014 to 2018 of the primary care teams implementing this effective tool to carry out early identification, early intervention, and delivering care and treatment to patients with substance use disorder and mental health conditions. Next slide. Then I'll conclude with this slide because I mentioned earlier on that the mission of the health centers is to increase access. And with respect to the opioid use disorder and addressing the opioid epidemic across our communities, we have been really looking to expand in the implementation of medication-assisted treatment with a focus on increasing patients served, increasing the number of prescribers among the primary care clinical workforce, and then finally increasing the number of health centers that provide medication-assisted services. So at this time, let me turn it back to the moderator, Ken, to facilitate the Q&A session.
Thank you, Dr. Lin. And thank you again to all the presenters for a wealth of information today. So we have a few minutes for a couple questions, and I'll direct it. So the first question that we have, sorry about that. The first question I have is for, I believe it was for, based on a comment Dr. Shukla mentioned, in terms of tox screening during COVID-19. So has, I guess, the clinics thought of using saliva-based drug testing at home with results submitted to the provider, in addition to just thinking about self-administration, observing self-administration of medication doses?
Yeah, that's a great question. I know that, so we convene a couple different convening groups, but one is of our local providers, including the OTPs, so methadone clinics. And I know the methadone clinics are using this, but we haven't really explored it. At MAHEC, we follow a more harm reduction model, so we haven't really had much hesitation to prescribe without having that objective data. But it is a great idea. I appreciate the comments, so we will look into that.
Great. So our next question, the two-parter. So first for Dr. Poitevien, you mentioned that you were able to give away some phones to patients that required them. I guess one of the questions is, how were those phones funded for?
Yes, well, we actually got them ourselves. We got 150 phones with, the idea was that it was a 3-month contract that we got with, I think, Verizon, and we felt that it was worth it. We hope to build that in the future to some of our COVID recovery fund, but that's, it was self-funded.
Great. And related to that, Dr. Shukla, so part of that question that was asked is about, giving away free phones, but what about in the case for rural patients when internet access at home, it can be spare, and sometimes they don't even have a personal computer. So do you have any tips on being able to engage patients in areas where internet access or telehealth may be very difficult?
Yeah, so what I've seen done is that patients are pretty resourceful. So this is not a problem that existed just because of COVID. So patients will use county resources, whether that's the local library or the health department who might provide free Wi-Fi. And so I've seen patients, even for our psychiatry clinic, which is one of the buildings here on our campus, they've had patients with difficult connections just drive to clinic and park in the parking lot to use the internet to do a video visit. And that way they're not exposing themselves to germs and vice versa, but they're still able to use that. We've also piloted, and I think it's expanding, I'm not so involved with this, but with home visits, particularly for perinatal and newborn care, as well as for geriatric patients. So I know they're doing some of that with some partners. So I think we're kind of putting a patchwork of services together for our communities, similar to how the country is demonstrating some patchwork solutions, but it's been working pretty well so far.
Great, thank you for that. This is a question for Dr. Lin. So, COVID-19, we're all aware of the serious racial and ethnic disparities that have been laid bare due to COVID-19. So what has, HRSA been doing, thinking about in relation to decreasing these disparities, and as well as, connecting that with the opioid crisis as well?
Thanks, Ken, for that question. So in our most recent survey that we conducted in May 1, we started collecting the race ethnicity data because I think, for us, it was really finding out what was happening on the ground. I think in hearing from some of our health centers, they have been able to link the information back to the social determinants of health data that they've collected and found out that, those that are racial ethnic minority patients that are testing positive, a lot of it has to do with the type of jobs that they have, the housing circumstances that they're in that doesn't allow for social distancing, and then the level of financial resources that they have. And so I think for us, it is a call to further address the social determinants of health for the patients that we serve, because we know that they're disproportionately impacted by those factors.
Great, thank you for that.
Ken, can I add briefly to that? And I really appreciate being on a virtual platform here with Dr. Lin and seeing some of her slides, and which is why our project really is targeted to supporting FQHCs in North Carolina, because we know through data that is on the HRSA websites that FQHCs disproportionately provide care to underinsured rural people of color, people who've had interaction with the criminal justice system, people who are at the highest risk for overdose, really. And so I think one way that nationally as well as locally we're addressing the racial and ethnic disparities, not just for COVID, but for overdose, is really engaging FQHCs to be the source of primary care-based substance use care as opposed to siloing it into other places.
Thank you. And just to let people know, in terms of acquiring phones, iPads, and telemedicine equipment, it looks like the USDA does have the DLT program is currently open and offering grants to acquire those kinds of technologies. So just wanted to make people aware of that. We have one more question that we can get to, and I believe this is for Dr. Poitevien. It's, can you please describe in more detail the type of incentivizing for both methadone as well as buprenorphine to which you're referring to? This person that asked the questions in California and was not aware of any of those incentives.
Yes. It is something even myself living in New York and being a Suboxone provider, I wasn't aware until we tried to convert people. Our goal is to convert our patient to methadone. We don't provide methadone. Some people need methadone, but we think a lot of people don't. So we then discovered when we told the patients, you need to, why don't we start on Suboxone, that they get a transportation check on a monthly basis when they go to the methadone clinic, which kind of makes sense because if you force them to go every day for their methadone, then they get the transportation, but they get it in a lump sum. Bethany, do you remember how much it was?
I believe it's around $100, and it sounds like even though currently clients aren't required to go into their OTP as much as before, they're still getting the same amount.
Yeah. Yes. So listen, I'm not advocating to stop the incentive that people are getting for methadone, but I would, for us, for example, we have a viral suppression program with HIV where we give patients $100 every 3 months when they are undetectable. We are looking into some form of incentive. Our incentive are usually, we tie them to clinical outcome. So we are looking to develop an incentive, whether it's adherence to the LMAT treatment, but an incentive that would be somewhat comparable. Certainly, I don't think it's going to be $100 a month, but incentivizing also the Suboxone in a way that the patient don't lose that income that they get from methadone.
Thank you. And with that, we're going to wrap up this webinar. Thank you to all of our panelists again for this fantastic session. To remind everybody, a recording of this webinar, as well as the presentation slides, will be posted on our resources page of our website, where you can find a lot of other resources as well that can help you through delivering care during COVID-19. Thank you again, and we hope everyone has a great day.